Hi friends, so in this video we shall be discussing an approach towards a thyroid nodule. So the first step that is important in an approach to thyroid nodule consists of your history and clinical examination. So let's take a look at the points in nutshell that should be done in your history taking. The onset, progression of the swelling, whether there are compression of any neck structures, the features of hyper or hypothyroidism. Then if there is any presence of eye symptoms, any treatment received prior to the presentation of a thyroid nodule, any significant family history and community history with specific focus on the dietary intake of the iodine, right. And the clinical examination would include your thyroid examination, examination of the swelling proper, and to look for any compressive features or to look for the thyrotoxicosis sign like in form of eye signs, right. Now once this is done, then we measure the serum TSH level, right. Now if this thyroid stimulating hormone level is low, then we do a radioisotope scan. Now on this radioisotope scan, if it is a hot nodule, that means it is an overactive nodule, then we need to go for an iodine therapy or surgery. Whereas if it is a cold nodule on your radioisotope scan, then that means that there is no isotope uptake. So in such cases what we need to do is to proceed for an ultrasound, right. And also if your serum TSH level is high or normal, then in such cases also we proceed towards a ultrasound. So we do a high resolution ultrasound, which is usually in the frequency 7 to 13 megahertz. So what we check over here is that regarding the margin. So the features that I have described over here are the features suggestive of malignancy, like whether the margin is ill-defined, any irregular shape, a hypoechoic, a microcalcification presence, hypervascular, elastography, then the lymph node status and the architectural distortion. In your lymph node status, the features that are suggestive of a malignant lymph node include loss of fatty hilum, a transverse diameter greater than 7 mm, heterogeneity of the lymph node and presence of microcalcification. So now on the basis of this ultrasound features, they are classified into high or intermediate category, a low category, a very low risk lesion or a benign lesion. So in case of a benign lesion, we don't do a fine needle aspiration cytology, whereas in case of a very low, we do a fine needle aspiration only if the lesion is more than 2 centimeter. Now in case of low risk lesion, we do fine needle aspiration cytology only if the lesion is more than 1.5 centimeter, right. And in case of a high or intermediate lesions, we do FNA if the size is more than 1 centimeter. Now how do we classify this into high, intermediate, low, very low and benign? So if we look at this diagram over here, now high suspicious would include your microcalcification, hypoechoic and irregular margin, hypoechoic with irregular margin, hypoechoic taller than wider. Then if you see over here, it is hypoechoic, irregular margin and extrathyroidal extension. Then hypoechoic, interrupted rim calcification with a soft tissue extension and nodule with irregular margin suspicious of left lateral lymph node. Now your intermediate suspicious would be hypoechoic solid with regular margin and hypoechoic solid with a regular margin over here too. Now the low suspicious criteria would include your hyperechoic, right, hyperechoic solid, regular margin and a partially cystic with an eccentric solid area as demonstrated in this ultrasonography image. Now your very low suspicious would include your spongiform or a partially cystic with no suspicious feature, and a benign would be your only cyst. So we have further written it down here for you. So high risk feature include your solid hypoechoic or solid hypoechoic or partially cystic nodule with irregular margin, microcalcification taller than wider, extrathyroidal extension and rim calcification. The intermediate intermediate risk lesions would contain hypoechoic solid nodule with smooth margin without any microcalcification, ET, or taller than wider shape. Your low suspicious would be isoechoic, hyperechoic solid nodule or partially cystic nodule with eccentric areas without microcalcification, taller than wider and irregular margin. And your very low suspicions would include your spongiform or partially cystic nodule without any sonographic features, and your low and your benign would be including only your cyst. So, these are your sonographic features on the basis of which you classify the lesions into high risk, intermediate risk, low risk and benign lesions, and then you perform a fine needle aspiration cytology. Now, for this cytology we have this Thigh classification which is given in your standard textbook of Bailey and Love. So, Thigh 1 is your non-diagnostic, Thigh 1C is non-diagnostic cystic, Thigh 2 is your non-neoplastic, Thigh 3 is follicular, Thigh 4 is suspicious of malignancy and Thigh 5 is malignant. Now, there is another system which is your Bethesda classification, where category 1 is your non-diagnostic or inadequate, category 2 is your benign, category 3 is your ATP or follicular lesion of undetermined significance, category 4 is your follicular neoplasm, and category 5 is your suspicious of malignancy, and category 6 is your malignant lesion, right. And we have this images over here for you guys. So, this is your image A, like as you see over here for your image A. So, these are benign colloid nodules with your bland appearing follicular cells, as you see in presence of an abundant colloid, right. So, this is your category 2. Then we have this image B. So, if you see in the image B over here, which is your category 3 or atypia of undetermined significance. So, if you see over here, the follicular cells are arranged showing the nuclear enlargement of most nuclei, right. So, there is nuclear enlargement over here of the most nuclei with occasional intranuclear groove. So, there is enlargement of nuclei with an occasional intranuclear grooves, right. Now, we have this image C, which is your category 4. So, if you look over here in this category 4, you have this follicular neoplasm. So, this have this high cellular aspirate which are composed of your uniform follicular cells. So, the cellular aspects are composed of uniform follicular cells arranged in your microfollicles, right. So, uniform follicle cells arranged in microfollicles. Now, we have this D, which is your category 5, which is your suspicious of malignancy. So, if you see over here, you have the microfollicular groups over here showing your nuclear enlargement, right. So, over here the microfollicular group shows your nuclear enlargement and pale chromatin, right. So, this is your category 5, and then we have your category 6, right. So, if you see over here, you have this features of papillary thyroid carcinoma, where we have enlarged oval orphan Annie I nuclei, multiple intranuclear pseudo inclusions, right. So, this is your category 6. So, this was your histopathological images of the cytology. So now on the basis of what you get in your cytological findings, it forms the basis of your treatment. So if we see the treatment part, now if it is a non-diagnostic, then what we do is repeat your FNAC, right. Now if it is benign, we follow up the patient. Now if it is your ATP of undetermined significance or a follicular neoplasm, in such cases we repeat with your molecular testing or perform a surgery. Now if it is suspicious of malignancy or it is malignant, then in such instances we do a surgery. And for your molecular testing, the most important genes that have to be tested in molecular include your RET, PTC gene, PPAR, Y and PAX8 gene, then you have your BRAF gene and you have your RAS gene. So why is it important? Presence of mutation was strongly suggestive of cancer, right. So this is all about your approach to a thyroid nodule. So if we just revise this once again, so first step would be your history and clinical examination, followed by your serum TSH level, then it would include your ultrasound, then it would include your cytology. Now on the basis of cytology, it would include your treatment plan, which would be, if non-diagnostic, we need to repeat benign follow-up, AUS and FN, repeat with molecular testing or surgery. Suspicious of malignant, we need to do a surgery, right. Molecular testing, the important genes that we need to remember are RET, PPRY, BRAF and RAS. Now because presence of mutation in any is strongly suggestive of cancer.